I would like to say good morning, good evening, or good afternoon, depending on what part of the world you're attending this meeting. I would like to thank ISAC for hosting it, and especially Fijos Johnston, the executive officer, and also the study group of ESCMID on critically ill patients and the King's Critical Care for the collaboration.
And now we are going to start with Professor Matteo Bassetti from Italy. He is a professor of infectious diseases, Department of Health Science, University of Genoa, head and infectious diseases clinic, Policlinico San Marino Hospital, IRCCS, Genoa, Italy, and he is the head of Regional Department of Infectious Diseases, Region Liguria, President of Infectious Diseases, President of Italian Society of Anti-Infective Therapy. He is the chair of ESGCIP, spokesperson, Superior Health Council Liguria region. Professor Bassetti is the current chair of ESCMID, and the president of the Italian Anti-Infective Society. He has an outstanding work of infectious diseases with more than 1,000 peer-reviewed articles and more than 60,000 stations. Now we are going to listen to him. Thank you for joining, Professor Bassetti.
Good morning. I am Matteo Bassetti, Professor of Infectious Diseases in the University of Genova, Italy. So my task today is discussing with you about the role of new antibiotics for MDR Gram-Negative Infections. So this is my presentation. So let's start with my disclosures in the past 2 years, but I would like to start talking about gram-negative bacteria that actually possess multiple modes of antibiotic resistance, including beta-lactamases. You can see very well in this slide that we have 2 types of beta-lactamases. The serine beta-lactamases, represented by class A, class C, and class D, and these are the main names, ESPL and KPC in the class A, AMP-C in the class C, and OXA48 like in the class D. Then we have the metallobeta-lactamases, represented mainly by the class B, and here we have IMP and the MMV. So when we talk about the metallobeta-lactamases in 2023, WHO identified a major gap in activity of traditional antibiotics against metallobeta-lactamases, and in fact, they consider the big 5 carbaphenemases one of the main problems. And when you see almost 3 of the big 5 carbaphenemases are metallos, including IMP, VIM, and NDM. And these are the most common carbaphenemases reported in Enterobacterales globally. And the metallobeta-lactamase genes are highly mobile and accelerating their spread all over the world, and metallobeta-lactamase can hydrolyze almost all beta-lactams antibiotics, and these are quite common in Enterobacterales, but also in non-fermentative gram-negative like Pseudomonas and Acinetobacter. So when we look at the distribution of metallobeta-lactamase positive Enterobacterales among the carbapenem non-susceptible isolates, you can see very well that the 3 metallos, IMP, VIM, and NDM, are quite common all over the world, particularly in the Asia-Pacific area and in Africa, Middle East, but also in general globally. So in this study, the comparison was between data of the period 2012-2017 with the period 2018-2019, and you can see very well an important increase in the percentage of metallobeta-lactamase positive isolates. The situation in Europe is again very problematic. You can see very well we have actually around 30% of the Enterobacterales that present metallobeta-lactamases. So, but which is the natural consequences of the spread of multi-drug resistant infections in gram-negative, so that the mortality doubles with infection caused by MDR pathogens. You can see very well in Klebsiella. Look, this is the pool mortality with the carbapenem susceptible around 21%, with the carbapenem resistant around 42%, and the same is for Pseudomonas. But when we look at the situation specifically for the infection caused by metallobeta-lactamases producing Enterobacterales, these are associated with increased mortality. This is the in-hospital mortality for NDM or non-NDM. You can see 55 versus around 14%, and the same is for Vim in Klebsiella, and the same is for IMP in Enterobacterales. So every time there is an increase in mortality report for those organisms. So in this context, what do we have in terms of new options for treating this type of resistance? So this is the list of the main mechanisms of resistance: ESP, ALAPC, KPC, Metallos, OXA48-like, and you can see here are the inhibitors, including all the inhibitors and new inhibitors. And you can see that for KPC, for instance, so Avibactam, Elebactam, Vaborbactam, but also Zidebactam, Tamirbactam possess very high potency. And looking at the metallobeta-lactamases, you can see that the activity is not represented by the inhibitors. If you want to have activity against the metallos, you have to add to Avibactam aztreonam in order to cover. And for OXA48, we have Avibactam, and we have Rilebactam and Vaborbactam. So when we look at the new options, this is a table that refers to the antibiotics already approved and on the market. You can see very well that we have ceftolozane tazobactam, that is a very good drug for Pseudomonas. Ceftazine avibactam, good for KPC, OXA48. Cefiderocol, good for almost all the pathogens, including Acinetobacter, Pseudomonas, but also Stenotrophomonas baltophilia. Meropenem-vaborbactam, one of the drug of choice for KPC, similar to imipenem-vaborbactam, that has also an important activity against Pseudomonas. Aztreonam-avibactam, almost the drug of choice for metallobeta-lactamases in Enterobacterales. Plasmomycin, interesting, and eravacycline, very good activity, particularly for Acinetobacter and for Stenotrophomonas. But let's say something again regarding all the antibiotics. So, and these are new options for the future, and you can see that we will have the combination of cefepime plus other inhibitors like cefepime emmetazobactam, like cefepime taniborbactam, cefepime nacurbactam, and cefepime zidebactam. But also, particularly for Acinetobacter bovine, we have two very interesting drugs represented by cefepime zidebactam and durlobactam sulbactam, for which I will say something in my presentation. Let's start with the KPC. What do we have actually for KPC? So ceftazine avibactam is probably the drug of choice for KPC. There are a lot of studies supporting its activity, lower mortality for Casavi in comparison with the best available therapy, also in monotherapy. The prolonged infusion was protected, so for ceftazine avibactam, and I think, actually we know that ceftazine avibactam is one of the drug of choice for KPC. Same for meropenem-vaborbactam. This is the study called Tango 2, which meropenem-vaborbactam was compared with the best available therapy, and you can see here mortality report for meropenem-vaborbactam was lower than the mortality report for the best available therapy, and mainly were Enterobacterales producing KPC, so an important reduction. The third drug is imipenem-vaborbactam, and even imipenem-vaborbactam in this study demonstrate to reduce the mortality for imipenem-resistant gram-negative infections in comparison with the colistin combination. So you can see here all-cause mortality less than 10% for imipenem-vaborbactam, and also an important reduction in the nephrotoxicity. And similar data are also the one for the credible study for cefiderocol. And in fact, then we can discuss about Acinetobacter or Pseudomonas, but for Klebsiella in this study, cefiderocol demonstrate to be better than the best available therapy. So what do we know regarding Avibactam? So Avibactam has been developed for working for metallo-beta-lactamases. So the studies, the phase 3 studies are two. The revisit, that was a prospective randomized open label in which Emblaveo and in which Avibactam has been compared with meropenicillin, and then the assemble one in which the drug has been compared with the best available therapy in patients with metallo-beta-lactamases infection. And in fact, in the study, you can see very well here, very small numbers, only 12 patients treated with Avibactam and 3 patients treated with the best available therapy. You can see here the clinical cure in metallo-beta-lactamases in Enterobacterialis was higher for Avibactam. And with this study, the drug was approved for the use in Enterobacterialis metallo-beta-lactamase producer organism. So what do we know in KPC actually? So in Enterobacterialis carbapenem-resistant producing KPC, we analyzed the mortality, and we were able to demonstrate that this was before the introduction of the new antibiotic. You can see a difference in mortality report for a Klebsiella pneumonia susceptible to carbapenem in red and resistant to carbapenem in blue, and you can see how big was the difference before the introduction of the new antibiotics. With the introduction of new antibiotics, including ceftazine avibactam, mortality for ceftazine insusceptible and ceftazine resistant is exactly the same. So new options permit to reduce significantly the mortality related to the resistance. So what do we know regarding other antibiotics? Cefepime M-metazobactam is a very potent drug active against ESBL. So the M-metazobactam restore the activity of cefepime against ESBL. And this is a good option for treating patients with urinary tract infections. And in fact, in this study, in which cefepime and entazobactam has been compared with the piperacillin and tazobactam, you can see how big is the difference in Enterobacterial ESBL producing, with much higher efficacy for cefepime and entazobactam in comparison with the piperacillin and tazobactam. So very good option for treating ESBL. So what do we know regarding other new options? Cefepime taniborbactam. Cefepime taniborbactam is an inhibitor with in vitro activity against producer of class A, B, but not IMP, and D carbapenemases, and is very active against carbapenem-resistant Pseudomonas aeruginosa and some KPC3 in resistant to Casabi and Enterobacterialis. So recently, the registration trial has been published, and I have written with Daniele Giacobbe an editorial in which I sustain cefepime taniborbactam with a certain one study, and for using in treating many types of infections, particularly for carbapenem-resistant infections. So we will see the drug available in the future. So moving to Pseudomonas aeruginosa. So what do we know regarding the drugs active against Pseudomonas? So actually, probably one of the best drugs active against Pseudomonas is ceftolozane tazobactam. And in fact, in this study, you can see the high potency of ceftolozane tazobactam against susceptible organisms, but also against resistant organisms to cefepime, ceftazine, and piperacillin and tazobactam. So ceftolozane and tazobactam demonstrate to be a good option in the head-to-head study against meropenem, and in against meropenem, demonstrate to be better than meropenem. Not only in Pseudomonas aeruginosa, it was the microbiological response in patients with ventilator-associated pneumonia, but also in ESBL enterobacterales. So ceftolozane tazobactam is a very good option for Pseudomonas, but also for ESBL. So this is a study that I published with my group, the first name Antonio Vena, and this is the comparative effectiveness of ceftolozane tazobactam in comparison with polymyxin or aminoglycoside containing regimen. And you can see that the clinical cure, even if it was not statistically significant in patients with nosocomial pneumonia and bloodstream infection, demonstrate that ceftolozane tazobactam work better than polymyxin, aminoglycoside, and there are also less side effect, particularly for kidney side effect. So another interesting option for Pseudomonas is also imipenetrabactam. So this is the activity maintained by imipenetrabactam against strains not susceptible to ceftolozane tazobactam and also to ceftazine-avibactam. So the drug maintain a very potent activity. You can see against Pseudomonas with more than 90% activity against Pseudomonas aeruginosa. And imipenetrabactam in real life, this was a study published a few years ago just to demonstrate that imipenetrabactam remain a very good option for treating Pseudomonas aeruginosa, even the one multidrug resistant. And in the study, the data demonstrate an interesting data regarding clinical cure and mortality data. What about cafidarocol for treating Pseudomonas? So these are the activity of cafidarocol in comparison with the other options. So these are data based on the Italian data, and you can see that cafidarocol for Pseudomonas aeruginosa remained most active drug, more than the activity, more than microbiological activity of colistin, ceftazine-avibactam, and also the one of ceftolozane tazobactam. So if you want to cover better Pseudomonas, probably cafidarocol actually represent one of the main options. Last but not least, Acinetobacter. So what do we know about options for treating Acinetobacter? Actually, we have new options. One is cafidarocol and the other is durlobactam. So let me say something about cafidarocol. So in the credible study, the data for Acinetobacter were not so good, but there were some limit of the study, small number of control group, abnormally low mortality in the control group in the study, and at the end there was an imbalance mortality between groups because there were more moderate or severe renal dysfunction, more ICU admission in the ICU randomization, and ongoing shock at randomization in patients treated with the cafidarocol. This was one of the reasons why, one main reasons why the data were not so encouraging for Acinetobacter. But looking at other experiences, and this was a meta-analysis conducted by Gatti, and in this meta-analysis they include also the credible data, but also many other studies in which cafidarocol was used for treating carbapenem-resistant Acinetobacter baumannii, and you can see very well that overall in the systematic review and meta-analysis of mortality, cefiderocol demonstrate to be better than the best available therapy for treating than the comparator for treating Acinetobacter. You can see a diamond that show a very important benefit. Cafidarocol based regimen were associated with a significantly lower risk of mortality in respect to comparator regimens. So what do we know regarding other options? So, and sulbactam durlobactam is a very good option in this study, the head-to-head study, sulbactam durlobactam plus imipenem versus colistin plus imipenem. You can see very well here the 28 days mortality was lower for durlobactam in comparison with colistin, and even higher clinical cure and less nephrotoxicity. So this will represent probably for the future one of the main drugs for treating Acinetobacter baumannii. And this is the Kaplan-Meier survival rate for sulbactam, durlobactam, and for colistin. So an important reduction in the 28 days all-cause mortality using sulbactam, durlobactam in comparison with colistin. So what about other options? So eravacycline. So eravacycline has a very interesting activity against Acinetobacter baumannii. So these are some data published a few years ago, and you can see very well that the MIC 90 is 2 times lower than MIC report for tigacycline, that is one drug that should be used for treating Acinetobacter. And we have a lot of data supporting eravacycline in Acinetobacter baumannii case series report, and this is a total of 10 patients that were treated with tigacycline and with a very good outcome for this antibiotic. So let me conclude, say 2 important points. The first one is how to predict an early appropriate therapy for patients infected with the carbapenem-resistant gram-negative pathogens in Italy. So we conducted this study together with some colleagues, and it was published in 2024 in Antimicrobial Resistant Infection Control. And we analyzed the Italian carbapenem-resistant rates, and you can see that in Acinetobacter 80-90, in Klebsiella 25-34, Pseudomonas 14 to 26, in E. coli 1%. And in those, there was also the impact of the COVID. So we analyzed the prevalence of gram-negative isolates in Italian ICU, and we combined with the susceptibility from Artemis surveillance study, and at the end, we tried to have a likelihood of therapeutic coverage of antibiotic treatment against suspected bacteria. So for having an empirical therapy, and the data are quite potent. Look the activity of cefiderocol. That was very similar of the one of colistin. So against Acinetobacter, the percentage of susceptibility and the predicted coverage in meropenem resistant was 20% for, and you can see very similar to the one of colistin. So and the overall, the predicted coverage overall was 95%, 95.7 for Acinetobacter, Pseudomonas, Klebsiella, and E. coli. Very similar to the one of colistin, but with different PK/PD characteristics. So in conclusion, let me say something about colistin. There is any more role for colistin in gram-negative infections? I believe that there is absolutely not anymore any role for colistin, at least in countries in which new antibiotics are available. Stop the use of colistin, please. So, and in conclusion, what can we say about the difference of the new antibiotic versus the old? For KPC, for OXA48, new antibiotics are the drug of choice. Ceftazine, avibactam, meropenem, valbactam, imipenem, elebactam, and only second line cefiderocol for KPC and OXA48. For metallobeta-lactamases in Enterobacterales, Avibactam is the best drug, or cefiderocol. For Pseudomonas aeruginosa not expressing metallos, ceftolozane, tazobactam, and imipenem are very good options. For Pseudomonas aeruginosa producing metallos, cefiderocol remains the drug of choice. For Acinetobacter baumannii, actually we have cefiderocol, durlobactam, sulbactam, but also a potential role for eravacycline of the new options. So this, I think was the last slide. So for the one of you that want to have the slide, please register on the website www.hti.net. It is free of charge, and you can be part of the HTI community. Thank you very much for your kind attention.
And now Professor Makris is specialist in respiratory and critical care. He's professor of critical care medicine of the University of Thessaly and divisional director of medicine and director of the relevant ICU. He has worked in Greece and in France, and also has visited in UK, visiting professorship. His academic output includes more than 150 reviewed publications, and he focuses on respiratory infection, ICU infections, COPD, and interventional pneumology. He has been active in national scientific societies. He runs directs postgraduate education and maintains an extensive academic and clinical presence in the field of respiratory medicine and intensive care. Welcome, Professor Makris, and thank you for being with us.
So I'm going to underline in the next 20 minutes some points regarding the use of antibiotics in this era, where a major problem in the ICU and in all other facilities where there are critically ill patients with severe infections is how to continue, drive and navigate on a pathway that you know and the outcome is certain and the outcome is positive. However, we know that there are certain issues with some bacteria where there are limitations and there is a narrow pathway that you have to go, you have to navigate, and you have to find the best outcome. And that is where the old, let's say, antibiotics come to, again, on the surface. I think we all know that, and Professor Bassetti saw just in his slides that metal-B-lactamases is a real issue here, is a real issue that hasn't started, let's say, recently. Metal-beta-lactamases has been described since the 60s, and there are several time points which are important for their development. And we are now in 2025, where you do know that the incidence of this type of infections caused by MBLs are continuing to rise and contribute to a clinical problem. And I think this publication from Italian centers in 2024 probably is the largest epidemiological study we have for MBLs, showing their clinical relevance. As we see on the left side, where you can see the susceptibility of bacteria to several different antibiotics, you can see that the best in vitro activity we have with colistin, with ceftazidime avibactam in combination with aztreonam. Then we have with colistin, and then we have with tilgecicline and fosfomycin. Cefiderocol, which is a relatively new antibiotic, has a low percentage, as you can see, around 30%, as it is also with aminoglycosides. And if you can see on the right side, the clinical data we have from this large study with more than 300 patients, you can see that the mortality rate when there is no in vitro active therapy for this type of infections, mortality can rise to 80%. And the best survival we have with a combination of ceftazidime plus aztreonam or other active antibiotics, which I will talk for later. I think also Professor Bassetti showed that the suggested approach in this on these grounds are the ceftazidime avibactam in combination with aztreonam, which is actually the representation of guidelines, or cefiderocol as monotherapy. But if you go easily through the web, you will see that there are several algorithms regarding the management of this situation where older antibiotics, not only aztreonam, which is an old one, combined with ceftazidime avibactam, but also older antibiotics such as fosfomycin or colistin are present on these algorithms. And I will start with aztreonam, which is a drug that was discovered in 1978. This is, I think, the first publication in 81, showing that aztreonam, actually the only monobactam we have in clinical use, it is really useful because it is not hydrolyzed by MBLs, and this comes to our question, owing to poor non-productive binding. with these enzymes. However, most MBL-producing strains co-produce extended spectrum lactamases that hydrolyze aztreonam. So a combination with BLIs, beta-lactam inhibitors, is used in practice. Now we have this epidemiological studies. This is the first one we have with about 100 patients from a center in Greece and 2 centers in Italy, showing that the use of aztreonam as a combination with Cazavi had a far more better survival compared to other options. Of course, it's not a trial. It's an epidemiological observational study, but we will have this in our mind because actually I think many of our recommendations are based on this and on the study I will show you just later. I just underlined that this study was rather a study on inhomogeneous population, since it has included both intubated and non-intubated patients. Definitely, it wasn't an ICU study, entirely ICU study, I mean. And it occurred that aztreonam was the choice, if you can see the data on the table, for, let's say, less severe patients, less intubated outside the ICU, less immunocompromised, less COPD or AKI patients. So this survival will have with about 80% of aztreonam, with aztreonam plus Cazavi. One might say that it refers to the best of the population, of the patients in this population. However, this number of about 80% survival is reproduced in this paper 3 years later with 300 patients, where you can see that this regime based on aztreonam and Cazavi has been associated with the best survival and compared to the other groups of the population. And if you see, there is also a multivariate analysis showing that this regimen was actually an independent factor for survival together with septic shock and AIDS. Of course, it is not probably the specific combination with Cazavi. Actually, we use, I think, aztreonam with another beta-lactam inhibitor combination, such as meropenem, vaborbactam. You may also reach similar results. This is a study from 2024 showing that the susceptibility with the combination is far better than with each drug alone in this context. These results that have been shown by the last 2 studies, the largest epidemiological studies, have been also reproduced from other centers. This is a study from Greece with patients, included patients with VAP, showing that the combination, even there is, as you can see, a small group of patients that had this treatment, is comparable to the control group of that study, which was actually patients with other bacteria having treatment with antibiotics that were sensitive to the bacteria. And from the same group, we have also a similar study, not for VAP, but for bloodstream infection, showing again that mortality that can be achieved compared to controls to patients with infections that are susceptible to antibiotics are similar, at least not statistically significant with, again, I underline with the small numbers you can see here. The same center with another one, Greece, has also produced this study, again comparing Cazavi plus aztreonam compared to controls or compared to double carbapenem treatment, and I will go a little bit with a parenthesis further on that, showing that mortality in the 3 groups are comparable. So you could say that this combination based on aztreonam, if you want, can achieve similar, in this epidemiological study, similar outcomes in terms of mortality. taking into consideration these numbers of the population with a control group that presents, let's say, less severe infections. I'll conclude this parenthesis for double carbapenem treatment because actually it could be also, it might be also an option. The concept of using two carbapenems is not new. It was introduced by Baglik and Nicolaou in 2011, and there were some studies in Greece and in Italy showing that when you use two carbapenems, one, let's say, to be killed by the enzymes of the bacteria, leaving the second one to be effective against the bacteria might be a clinically effective strategy. This study, you can see on the right that it is related, it's a study of this year, in 2025, was published, showing that the in vitro evaluation of dual carbapenem combinations against carbapenemase producing Pseudomonas aeruginosa, and you can see in the table that MBLs were included, suggested that if you use the two carbapenem strategy, may be effective at least in vitro against the MBLs. Let's say it's a complementary, something that completes this idea of using two carbapenems if you add it on the data you have from the studies from Greece and Italy for the use of the two carbapenems. Now, the other agent I would like to discuss about is fosfomycin. It's an agent of the 70s, an antibiotic class of its own, and has actually a bactericidal activity that it is good also for under anaerobic conditions and low pH, and it presents efficacy against a wide range of Gram-negative and Gram-positive pathogens, having, I think, a unique behavior in the tissues, since it has a negligible protein binding of almost less than 2%. The tissue pharmacokinetics suggest the saying that if you use it in critically ill patients, that can achieve on the target tissue relatively fast, as you can see here from the first study, which is on bone and muscles, and on the second study, which is on the lung. It can achieve fast rise on the target tissue, and I will connect that the concentrations on muscle and bones tissues that were achieved were very important and high. And the first study was with microdialysis, which one might say it is a far more better way to assess the concentration in the tissue than the second study, where it was a bulk study in 37 healthy volunteers, showing that there was a fast and rise on the lung parenchyma of the concentration of fosfomycin, but actually the ratio between plasma and lung, it was about 30%. Now we consider fosfomycin. That could be also an option for the metallo-beta-lactamases. And actually this has started from reports we have from the Asia, mainly from Thailand, showing that fosfomycin in both ESBL and MBL cases, as you can see here, it can reach a susceptibility compared to other, far more better compared to other antibiotics. Actually, fosfomycin was 90%, whereas tizecycline or netilmicin was about 20 and 32%, and it was only colicin who had a better susceptibility. Again, from, let's say, a similar geographical area, you can see that the fosfomycin susceptibility among MBL producers reached 90 and 80%. There are some studies, clinical studies, such as this one, I think it is also in Thailand, showing that among 100 diagnosed cases, where 60 cases had mostly MBL producing bacteria, fosfomycin-based regime was associated, I would say, with a higher survival compared to other options. I will just make clear here that also the number of cases treated with fosfomycin was a minority, 23 cases out of 134. And although there was a multivariate analysis associated fosfomycin with survival, this was not true in the univariate analysis, as you can see on the table. If we go to the studies I've shown you before, and if we go to the last group, which is the other active antibiotics that actually present the lower mortality even compared to ceftazidimab, avibactam plus aztreonam in terms of arithmetically speaking, because statistically there was no statistically significance suggested. If you see that these other active antibiotics essentially are fosfomycin-based regimes, fosfomycin plus gesiklin or fosfomycin alone. And there are some other studies. I will not go further for fosfomycin showing that combination with another drug, it may be an option for pan-drug resistant Acinetobacter baumannii bacteria, for example, even we don't know here if it was if these cases were MBL cases. Now, I left colistin or polymyxin E for the end. Historically, it was used, even from the 50s. Excuse me. It has certain characteristics that may its use, I would say, limited. 20 to 25% of colimystin is converted actually into the active metabolite. It needs more than 36 hours to achieve the target serum concentration, even with a loading dose that actually is 9 million international units or 300 milligrams of colistin. And less than 40% of patients with normal renal function can achieve such a steady-state concentration. There is also an issue with the lower respiratory tract concentration, which is maybe hard to be reached. And that's why there is here a space for nebulized use of colistin that may increase its concentration in the lungs. The issue with the concentration achieved can be shown in several studies. This is a study showing the association with polymyxin B, not polymyxin E, showing which is easier to measure it. So if you can't reach a concentration of, let's say, 1.3 milligrams per kilogram per day, this is not associated with survival compared to those who will achieve this concentration. Even though colistin in vitro, its activity with MBLs, it's remarkable, as you can see here from this data set. I think it comes from North American based data set base, showing that colistin, it may reach 90%. And you can see here there are several other percentages regarding susceptibility. There are some studies from Asian-based countries, mostly showing a good clinical response at the end of treatment with polymyxins. However, we have these two studies, the epidemiological studies with MBLs, where although in the first one with 100 patients, the susceptibility was 90%, so one might expect a good outcome. Actually, the mortality which was associated with this regime was about 50%, far less than the mortality and survival, if you want, with Cazavi plus aztreonam. And these actually were reproduced in 2024, where you can see that the regime based on colistin had the lower survival, although we should underline that the patients who, the population of patients who used colistin was only 7.6% of the whole population. So to summarize, what we do have here is that aztreonam in combination with Cazavi or with another BLIs may be the best option, clinically speaking. However, we know that there is a lack of aztreonam, and many will struggle to find it. So the other options, I think, could be fosfomycin, which is associated with promising results, but certainly larger data sets needed, especially in lung infections. Colistin, which is good in vitro, but there is a limited impact of it, possibly to its chemical characteristics. And there is an open parenthesis regarding the double carbapenem treatment, which might be an option. This has to do with the old antibiotics, and you have my regards from Larissa, which is a city in Greece, and actually its name means in ancient Greek castle. So old antibiotics from an old city. Thank you very much.
Thank you very much for the great presentation. Now I'm checking the questions, but I only see just one question. Let me start with my question. Could you provide the rationale behind the use of double carbapenem administration? Well, perhaps we can consider higher dosages rather than using two distinct carbapenems. Why should we prefer, double carbapenems rather than higher dosages of a single carbapenem? What do you think?
The concept, as it was introduced in 2011 by Nicolaou, is that if you start with the two carbapenems and the one of them is ertapenem and you give at the beginning ertapenem, then the bacteria will hydrolyze first ertapenem, so they will leave space for the second carbapenem to act and be efficient. This is the concept of using it, and as it was developed back 15 years now ago. Now, I can't say more about that because I have.
Okay, sure. This is the recorded data. Thank you. Yeah, that's great. There's one more question here from Marina Jagannatha Rao. According to the UCAS 2025, she says, fosfomycin is to be used only against E. coli and a urinary isolate. I think this is a basic issue. So this is the question: should we use fosfomycin for systemic infections, etc., and for isolates other than E. coli?
I think I show you that the recommendation that doesn't recommend fosfomycin. There are some algorithms suggested by scientists that include fosfomycin, and the need to include fosfomycin is when you don't have any other options. And I think, for example, in my clinical practice, we don't use fosfomycin widely, but if you do not have aztreonam, and this is something that happens very regularly, then you have to go and find a different option. So we have also used fosfomycin, but there is no definite clinical trial to answer something more about that. And there is a certain level of recommendation regarding its use.
Thank you. Perhaps we can get...
Sorry, there is a question from Jean-Francois.
Hello, thank you very much. Thank you, Demosthenes, for this very nice talk. I have a question about double carbapenem in MBL producers, because you mentioned it, and usually it is considered that the affinity of ertapenem for MBL is not so good. And there was some data suggesting that the double carbapenem will not work as well with MBL than with OXA48 or CAPC. And I wonder if the MIC...
I think there may be a failure. Oh, no, it's okay.
You are muted, Jean-Francois. Okay.
I wonder if the MIC of meropenem in this study have been measured, because most of the time we consider that over 8, it is quite impossible with a double carbapenem to reach sufficient activity to be clinically effective. So what is your point of view about this?
I'm very skeptical about the use of double carbapenem for the reason you have underlined, but I just wanted also to report it as an option. There are limitations, and actually, I think that's why the concept has not attained, let's say, more success, even it was introduced 15 years ago. However, in difficult cases, and if you don't want for any reason to use, for example, you don't have Astreonam, you have, let's say, an resistance to colistin that may happen also. And you have so the options of fosfomycin. One will say that fosfomycin cannot attain a good concentration in the lung and doesn't believe it at all. And you are left of any option at all. So we'll, based on the Massimo Santonelli study, and whatever we have also to use it. I believe that with the introduction of novel agents that Bassetti, I don't think you have mentioned that, we may have more options. But regarding the older antibiotics, I think these are roughly the options we have.
Thank you.
I would like to present Professor Jean-Francois Timsit. He works in Bishop University Hospital in Paris, France, and he is the head of medical and infectious diseases ICU, and he is the president of Outcome REA Research Network, president of the Central Infection Unit, and the Public Assistance Hospitals of Paris. I think I have translated from French, and he is the research officer of ESCMID. His research interests are sepsis and antimicrobial therapy, antibiotic resistance, catheter-related infections, ventilator-associated pneumonia, multidrug resistant pathogens, improvement of quality of care, and also he is focusing on prognostic models and with high-quality databases. So he works in critical care, infectious diseases. His work is very exceptional with more than 700 articles, and his age index is 97. Thank you for joining us, Jean-Francois. The floor is now yours. Okay, thank you.
We will discuss the data about the appropriate therapy, short versus long in stable patients. We will discuss the recent advance with large cohort and randomized control trial, and discuss the fixed and individually planned duration of therapy, and we will finish with uncertainties. If we look to the data on the past 10 years, there is a lot of data that suggests, for example, in a randomized control trial, is with BSI due to gram-negative bacilli, but out of the ICU and stable and afebrile patients, it is feasible to decrease the duration of therapy because it is non-inferior to a prolonged therapy in terms of relapse, death, recurrence, readmission, rehospitalization. And even for non-fermentative gram-negative bacteria, there is at least 2 cohort studies that show that in a very specific group of non-fermentative gram-negative bacteria out of the ICU most of the time, without infective endocarditis, device infection, and not complicated BSI, it is also feasible to reduce the duration of therapy to, let's say, 7 to 11 days as compared to a traditional 3 weeks treatment. Even for Staph aureus, there is really a discussion because if we look, for example, to the study from Switzerland, they compare a short and a long duration of therapy for Staph aureus, separating and dividing the population into 2 groups, a complicated one and an uncomplicated one. And once again, when the BSI was not complicated at all, it is also feasible to decrease the duration of therapy. But it was not the case in case of uncomplicated case where there was a higher risk of relapse, reinfection, in case of complicated Staph aureus bloodstream infection. So to conclude this slide, for mild and uncomplicated case, well, probably it is feasible. But we don't know for difficult to treat resistant bacteria, and especially we don't know for those patients which are really unstable. So, of course, the balance trial was really important to look at it. It was, as you know, a very high and a very large randomized controlled trial comparing 7 to 14 days in bloodstream infection, including patients in ICU. It was 74 hospitals, mainly in Canada. The intervention was concealed until day 7. And the ITT patients were all the patients, and MITT was those patients who were alive at day 7. They calculate the effective to demonstrate a non-inferiority margin in terms of day 90 mortality of 4% using a baseline mortality rate of 22%. Of course, you should have a very important look of the exclusion criteria in this study. All the patients which were immunocompromised were excluded. Those patients with prosthetic heart valve and endovascular graft, those patients with infective endocarditis, undrainable abscess, pacemaker, prospective joint infection, and more importantly, those patients with Staph aureus, Staph lugdunensis, and Candida species bloodstream infections were excluded. And in this study, where there was indeed 55% of ICU patients, there was a population that was very complex and did not completely reflect the ICU population. Indeed, it was patients that were most of the time not ventilated, many immunocompromised patients, mainly community-acquired infection, with more than 40% urinary source as a source of infection, questioning about the external applicability of the results. But if we look to the results, indeed, 7-day treatment was associated with even a lower risk of death than the 14 days group. And if you look to the antibiotic-free days, there was -5 days of antibiotic therapy and no adverse events. But if we look into details to the molecules that were given to the patients, it is mainly, let's say, drugs associated with susceptible or perhaps some MDR bacteria, but very few data about the patients with really high-risk microorganisms. As you see, the number of broad-spectrum antimicrobials that were given in this study was not so large, and there was no DTR infection in this study. Also, there was a lot of other concern. More than 4,000 eligible patients were not included because of physician decision and questioning about the external applicability against. If you look to the mortality at day 7, it was only 0.8%, and it is not reflecting perfectly the ICU population. There was, again, a low-level risk of resistance. And of course, and very importantly, the adherence with the 7 and 14 days therapy was not so good. And there was more than, for example, a quarter of patients in the 7-day group that receive far more than 7-day therapy. And there was no data in the ICU group. It was interesting to look at the post-hoc analysis in this study because I try to take into account the absence of adherence to the protocol. And they use a Delphi process in order to define what are the way the physician and the investigators choose 7 versus 14 days of therapy. And they define using a Delphi process a static decision rules at the very beginning, a dynamic stopping rules at day 7, and an early clinical failure rules at day 4 order to differentiate those patients that are at risk of poor evolution as compared to the others. And clearly, they defined 3 scores and 3 groups according to these decision rules. And they demonstrate that there is a clear association, very significant association, between these scores and the prognosis of the patients. And they perform the analysis using this low, medium, and high risk of relapse and failure for all this definition. As you see in this slide, the adherence for the high-risk group was not so good. It was only 2/3 of the cases. But nevertheless, if you look to the results of this post-hoc analysis, there was, even for high-risk population, no problems with a 7-day therapy. And to conclude this post-hoc analysis, in a selected population, the traditional argument for prolonging therapy at day 0, day 4, or day 7 did not affect the absence of worrisome effect of a 7-day course on day 90 mortality. That is to say that perhaps in the most severe patients, it is also feasible to perform a 7-day therapy. Of course, a lot of limitation, as I talked about before, but really an interesting point. So probably 7 is nearly similar to 14 days. Very severe critically patients were excluded. The other immunocompromised patients were not included. There was a question about the incomplete source control in terms of duration of therapy, and a question about non-fermentative gram-negative bacteria, difficult to treat gram-negative bacteria, and of course, Staph aureus and Candida. We perform a post-hoc analysis of the EuroBac-2 trial, which is, of course, as you know, hospital-acquired bloodstream infection admitted in ICU, and a very particular group of patients of 500 patients, that is to say, no more than 20% population, are accessible to a short-term therapy because they have an appropriate antibiotic therapy within the first 3 days, and no reason, no indication for a prolonged treatment. And we compare 7-10 to 14-21 days. And in this study, first, we found that the duration of therapy in ICU for BSI is 11 days in median, so very, very long. And when we adjust on many, many factors, especially the duration of therapy was longer for DTR BSI, longer for Staph aureus, and longer when we use combination therapy. When we adjust about all these points using modern statistics, let's say, we found that the treatment failure at day 28 was even better. In a short therapy group, you see the day 28 mortality, the persistent infection, and the subsequent infection. So in a selected population, no more than 20% of the ICU population, it is feasible and probably associated with even a better prognosis to decrease the duration of therapy. And we will look at it after. Of course, there is also data, for example, for peritonitis. For very severe postoperative peritonitis included by Philippe Montravers a few years ago in a randomized controlled trials that demonstrate that 8 and 15 days of antibiotic therapy was quite similar. And there was a significant gain in terms of antibiotic-free days using a short-term therapy. But there was more subsequent drainage between day 8 and day 45 in a short group, indicating that perhaps it is associated with some failure. If we look to the real duration of therapy in this study, it was not the case. So, the duration of therapy was not associated with failure. And very interestingly, the presence of Staph aureus, Pseudomonas aeruginosa were not associated with an increased risk of failure. And it was the same for VAP. If you look to VAP, including bacteremic VAP, it is feasible to decrease the duration of therapy. It has been demonstrated by randomized control trial, and one recent meta-analysis of the randomized control trial suggests that it is safe. But again, it is associated with more recurrence. And it is a point that we have to have in mind. Although it is not associated with an increase in mortality or duration of stay, it increases the risk of recurrence. The characteristics of the bacteria is also very important and may incline to prolong the therapy. Suboptimal PK/PD, of course, is very important. Poor tissue diffusion, IMIC, lack of bactericidal effect, lack of post-antibiotic effect, and also the bug by itself, the biofilm formation is also very important, the presence of metastatic focus, and probably also the high inoculum. If you look to, for example, this hollow fiber model using piperacillin tazobactam 27 gram in prolonged infusion, reaching 100% time over fourfold the MIC for this pi1 infection. And you see, the first inoculum is only 10 to the 5th in these experiments. And in this case, there is only susceptible Pseudomonas aeruginosa and probably a cure at day 5. On the contrary, when there was a 10 to the 8 model, the 10 to the 8 inoculum density at the very beginning, there was an increase in a resistant population mentioned here in crude, and there is an increase in resistant population and a re-emergence and growth of a resistant Pseudomonas aeruginosa at day 5. So probably suboptimal PK, high inoculum are risk factor of microbiological failure. It argues essentially for optimizing the immediate PK. I think I hope you see my screen. No, sorry. Hope that it's okay. So it argues for probably for optimizing PK/PD more than for prolonging the duration of therapy. Of course, it is important because when you look to the duration of therapy in this study for DTA organisms, here is Acinetobacter baumannii, carbapenem resistant. You see that we are comparing duration of therapy with not the same pivotal antibiotic. And in some cases, here, for example, in this study, they show that cefiderocol is associated with a better prognosis as compared to colistin-based regimen. But the duration of therapy was longer in the colistin-based regimen as compared to cefiderocol. So we don't know if it is the duration of therapy that is associated with more failure or the pivotal antibiotic. And I think it is an important point to address in the future. Of course, for DTR, especially for Enterobacterales, it is not suggesting by the recommendation to prolong the duration of therapy due to DTR. So the message is the resistance per se is not an argument to prolong antibiotic therapy most of the time. There was some analysis, some cohort studies about carbapenem-resistant Enterobacterales. This one published by the Pranita Tama group. They look to the possibility to decrease the duration of therapy to 7 days, short course therapy in patients with carbapenem-resistant Enterobacterales BSI. It was mainly CAPIC in this study. All the patients were treated with new beta-lactam inhibitors in this study and performing a strong adjustment. Even with patients with more than about 30% of patients in the ICU, they showed in this study that there was no impact on a short duration of therapy if you select this kind of population as compared to a long therapy. And there is also other studies that has been published very recently. In a few words, if you have a good adequate source control, if you have a good clinical evolution at day 4, it is feasible to decrease the duration of therapy, even for carbapenem producing Enterobacterales or resistant Klebsiella pneumoniae infection. It was the case also for Pseudomonas and Acinetobacter baumannii infection here in this cohort published recently. And again, in a subselection, a subgroup of patients, only 1/3 of the patients, most of them are out of the ICU, so very stable. It is also possible to decrease the duration of therapy. And if you look into detail, the subgroup analysis to EuroBac2 trial, and if you look to MDR DTR infection, there is the same effect, the same trend for a better prognosis, even for MDR DTR organisms as compared to susceptible bacteria. The only group where the 7-day should be challenged is Staph aureus, and also is immunocompromised patients in ICU, where there is really no benefit for short-term therapy, and we need to have it on mind. The last point that I would like to look with you is the individualized duration of therapy. You know this study, it was performed out of the ICU, and they compare a fixed 7, a fixed 14 days, and a CRP-guided treatment. And they demonstrate in this study that the clinical failure was better for CRP-guided treatment. And you see the duration of treatment that goes for 5 to almost 20 days according to the evolution of the patients. So perhaps it is a solution. This solution has been tested in the ADAPT trial, not for severe infection, but for sepsis. And you should know that in this study, only 46% of the infection were documented. So it is really an issue. And if you look to the severity of the patients, it was mainly community-acquired pneumonia, some hospital-acquired pneumonia, mainly respiratory tract sepsis, let's say. And they compare a daily PCT-guided protocol, a daily CRP-guided protocol, and the standard of care. And in this study, they demonstrate that they decrease by only 1 day using PCT-guided algorithm, the duration of therapy without impacting the day 28 and the day 90 mortality. It is very interesting to have it in mind. First, the duration of therapy was quite long in all the groups, so it is important to have it in mind. Second, the adherence of the protocol was not so good. Many patients, you see the crude here, were on antibiotic, whereas it was suggested by the algorithm to stop antibiotic. So the adherence is very, very debatable. So it is really an issue for demonstrating that PCT guidance is better and individually followed is very difficult because we don't know how to individually manage the duration of therapy. It is really an art. And if we look at the subgroup of positives in the ADAPT trial, it was a better effect when the effect of PCT guided was better with BSI as compared to those patients without BSI. So it is interesting to have it in mind. So it is interesting, but not finished, and there is a poor compliance in the intervention. So to conclude, the duration of therapy is too long in ICU patients. It should be shortened, especially fully susceptible bacteria, of course, and in patients still severe at day 7, and probably even in case of multidrug resistant and non-fermentative gram-negative bacteria. It is still debated on Staph aureus and Candida infection, but there is probably a room for a short therapy in this case, and probably in case of immunosuppression. The optimal duration should be individualized, but we don't know the clear indicators or stopic rules at this point, and we need to work on it. And there is a need for systematic screening and indication of long therapy, and if you decide to stop the treatment, a watchful waiting is needed after antibiotic stop due to a tendency for more recurrent infection without impact on prognosis. Thank you for your attention, and sorry of being a little late and for the cut in the communication during this web.
Jean-Francois, thank you very much for your excellent talk. We have several questions in the chat. I will start with a question from Dr. Marjuki that says, in your opinion, what is the best indicator to stop antimicrobials in critically ill patient? And is there any reason to use antibiotics more than 14 days?
More than 14? 14 is very long.
Yes, so, 1/4, exactly.
When you have a small inoculum, when you have urinary tract infection, probably after day 4 or day 5, the treatment is finished. So we use 7 days, but I don't know why we use 7 days. Probably 4 or 5 is clearly sufficient. And in this case, probably a biomarker could help in order to decide when your patient is extubated without norepinephrine. Probably it is possible to stop very, very quick. The patient is still with signs of very severe infection, for example, high blood leukocyte level, fever, no decrease in SOFA score. It is very difficult to decide. If you look the patients that are very severe, of course, the organ dysfunction are not completely related to the infection by itself, especially nosocomial infection. So usually when I have, let's say, a stabilized patient, even under norepinephrine, I consider that after day 7, it is feasible to stop the antibiotic. Of course, if you have some patients with abscess, with empyema that are not completely drained, with peritonitis, with some abscess that are not drainable, you may be inclined to prolong the therapy. But most of the time, as I show you in these models, it is antibiotic-resistant strains that exist in this abscess. So you may be inclined to insist on the surgeon and the radiologist in order to perform drainage and not to continue the antibiotic in this case.
Hakan, further question for Professor Timsit?
I am not hearing you, Hakan, because you stop your mic.
You're muted.
Well, I am ready. So there are many questions here, and we can proceed with a couple of them. One of them here says, can we look at improving diagnostic in CCA for teams to feel more confident in stopping antibiotics sooner? CRP, PCT, or poor markers when it comes to stopping antibiotic. How should we balance the use of inflammatory markers in the sense of clinical decision making for Jean-Francois?
Well, for me, the clinical decision is the best way to do, but in some case you hesitate. You have the equipoise, you don't know, and if you have a decrease in the biomarker, it could be good to be inclined to stop the antibiotic. When you are sure of your patients and everything is okay, you can stop without biomarker. In case of, let's say, an hesitation, probably it is an added value to use it. But it is not the case when you are sure of your clinical decision. I think nowadays it is not feasible to do other things. And I think that antibiotic stewardship team is really interesting in this case. You should discuss with microbiological lab, look at the MIC, look at the intensity of the first treatment. It was good or not good. The MIC was not so good. If you consider that the patient is still in delirium, that the norepinephrine is not decreasing well, of course, it is more important than the biomarker by itself. So first of all, look at the clinic, discuss with colleagues, and after look at the biomarker if you have some hesitation, let's say.
Yeah, this is great. You know, we all face the same problems very well. There is a very nice one more question here, I see, coming from Anastasia. She asks if there is any data for candidal infections, and are these data, the bacterial data you mentioned in your presentation, is applicable to fungal infections?
It is a very interesting question. There is a study, only one, a cohort trial from Antonio Vena, I think, that has been published 2 years ago, and it suggests that in very unsevere patients, until there was, I think, 20% of ICU cases, in case of candidemia, when the catheters has been removed, the patient is well, it is feasible to stop antibiotic therapy before day 14. And it is probably the case for some patients. And there is some recommendation discussing it by the Cornelli team published very recently. So probably there is a way to decrease the duration of therapy for Candida, but it is not the rules. Let's say you should try to discuss it after day 7 if everything goes well and you are sure that the catheter has been removed and the patient goes well, there is no immunosuppression, and everything is good. But at this time, I think it could be the exception.
I'm moving on with Professor Antoine Roquilly from Nantes. Professor Roquilly works in Nantes University Hospital to Nantes and in the Center for Research in Transplantation and Translation in Immunology, and also in the Service of Anesthesiology and Critical Care. He also holds an academic affiliation with Australia, with the Department of Microbiology and Immunology and the University of Melbourne in the Doherty Institute. His research focuses on immunoinfectiology and host pathogen interactions, particularly in pneumonia. He coordinates major European projects, including the HAP2, that is the host-targeted approaches for pneumonia project, under Horizon 2020, and also the HOMILUNG project, another big European project, host microbiome interaction and long-term outcomes after pneumonia, again under Horizon, reflecting his leadership in translational research and the international collaboration. He has an outstanding and pioneering work in the field of immunomodulation with high numbers of publication in top journals, and we are honored that we have Antoine with us.
Thank you so much for the kind invitations to speak about immune modulation and hospital-acquired pneumonia. So today I'm speaking about this type of infection because we all know that they are very frequent, very difficult to treat, and even with the good applications of current recommendation for preventions of hospital-acquired pneumonia, we observe that still 30% of patients hospitalized in intensive care units in France, and it's the same in Europe and worldwide, will develop pneumonia. So it's very frequent. In my ICU of 27 ICU beds, meaning that 9 patients will or had developed pneumonia. These infections are very difficult to treat, even if you are using the good antibiotics. We recently showed by combining several international cohorts from France, Netherlands, Spain, and worldwide, gathering data from more than 4,000 people with pneumonia, that the risk of death can be increased in some subphenotype of pneumonia. And we can see if you compare very severe pneumonia with less severe pneumonia, that the mortality can be as high as 40% of patients. And also the risk of treatment failure, you can see in this circle plot here, is usually between 30 to 40%, meaning that 1 patient out of 3 with pneumonia receiving good antibiotics is not cured at the end of treatment. So these infections are very frequent, very difficult to treat. That's why a few years ago, we proposed a reappraisal of the pathophysiology of this disease, saying that, all right, the pathogen is key for sure. You need to try to eradicate pathogen and prevent the lung colonizations or contamination with this pathogen. But once the pneumonia has started, some other mechanisms started, and this is the concept of respiratory dysbiosis. So dysbiosis is not only a matter of microbiome. Usually people think about dysbiosis, think that all the bacteria you are all carrying on your skin, guts, and lungs are altered. But dysbiosis is also an alteration of the host microbiome interactions, because we know that the microbiome produces some metabolites that change the immune functions, and in response, the immune functions change the composition of the microbiome. So what we proposed in 2019 was that pneumonia is a dysbiosis, and the key factors will be to restore normal host microbiome interactions, not only to kill and eradicate the pathogen. So we performed several clinical trials and mice models to explore the mechanisms, because we still have no real demonstrations or treatment to propose based on immune therapies at this date. So one of the first treatment or study was to study the role of monocytes and alveolar macrophages, because myeloid cells are key in eliminating and doing phagocytosis of extracellular bacteria. And so we assess and measure the capacity of these cells to do phagocytosis. And what we observe is that very rapidly, during infections or even during any systemic or lung inflammations, the capacity of monocytes and macrophages from humans are decreased. As shown here, you can see that we can measure the phagocytosis, and it's decreased for months. So there is a very rapid alteration and, let's say, paralysis of these cells during and after pneumonia. Perhaps it's increased the capacity and the likelihood to develop a secondary pneumonia. So we move back to deep understanding of these cells, and we perform transcriptomic analysis and epigenetic analysis of patients at high risk of developing hospital-acquired pneumonia. For these patients who were hospitalized in ICU for brain injuries, we collected monocytes and we performed this high-throughput analysis. And what we observed in this study was very rapidly, from day one after ICU admission, so before pneumonia, we already observe a lot of differences. So there is a rapid immune adaptations to any critical illness. And you can see here that some of the pathways which are down-regulated before pneumonia are the cellular response to interferon type 1 and type 2. So based on this concept, this functional paralysis of monocytes and this decrease in the interferon gamma signaling pathway in blood circulating monocytes, we proposed a randomized clinical trial. It was a phase 2, a randomized trial testing interferon gamma versus placebo in critical ill patients at risk of pneumonia. So the aim of the study was to prevent pneumonia by boosting and restoring interferon gamma pathway in monocytes. It was a phase 2, meaning that we were aimed to include 200 patients, 100 with placebo, 100 with interferon gamma. So you can see here the design. It was very early in the ICU admissions. Patients were treated for 10 days with interferon gamma, beta 1, for 10 days, versus placebo, and they were followed up for 3 months. Here are the study populations. You can see that all the patients, it was an inclusion criteria, suffer from an organ failure, mainly comatose, but also hemodynamic and respiratory failures. All patients were ICU-induced immunosuppressed. So you can see that there is lymphopenia, and we have marker of immunosuppression such as low class 2 expression on monocytes. But the study has to be stopped after only 109 patients due to safety concern, because here is the primary outcome. It was the probability of being alive without pneumonia. And you can see these two curves here, and the line B, the dashed line, is interferon gamma, meaning that what we found after the inclusion of 50% of the study population was an increased risk of patients to develop pneumonia. So survival rate was exactly similar between the two study groups, but interferon gamma induced lung inflammations mimicking pneumonia in these patients. It's completely surprising at this time because it's the exact opposite of the hypothesis. Remember this concept of paralysis of monocyte, this defect in interferon gamma, and this overwhelming inflammatory response to interferon gamma. And that's even more striking that this treatment is routinely given to other populations of patients, and this toxicity in the lungs response has not been described before. So it's something specific to patients at risk of hospital-acquired pneumonia or adjunct pneumonia. We performed several subgroup analyses. All groups were in favor of the placebo, but you can see that perhaps we observe an interaction between steroid therapy and the interferon gamma, showing that steroids increase the toxicity or the response to interferon gamma, the inflammations. So this result challenged our concept of immune suppressions, because immune suppression is very important to understand what it is to design better immune therapies for severe infections. So here is the concept of immune tolerance or immune suppression. So if you move from the blue lines to the pink lines, is this patient immunosuppressed or not? You can see that in the pink line, patient will die quickly even for a small pathogen burden. But we all know that usually it's an over-inflammatory response. So these patients have an increase in the immune response and is dying from a small pathogen burden, as compared to the green line, where the patient will never die from infections, but he will have a high pathogen burden, so he's not able to eradicate or to clear the pathogens. Which line is the immune suppressions? It's not that easy to define. So we have performed two studies following these observations to understand what was going on. So we consider that if these patients at risk of developing severe sepsis were immunosuppressed, and we know that from the immunological assay that this defect lasts for years, we say this patient should have an alteration of the risk of developing cancer after sepsis. So we are not looking at the outcome of cancer present at the time of sepsis. We are looking at the number of new cancer developed in this patient with sepsis-induced immune regulations. And you can see that in red, the curve of patients surviving sepsis, the risk of developing cancer is decreased than 1. So immune suppression, immune programming, and increase the ability of the immune systems to fight against cancer. So we continue this work. We find that myeloid cells, and notably macrophages and monocytes, are involved in the process, and we may know, or you likely know, that we have two kinds of alveolar macrophages. Some one are resident; they are always there in the lungs. In your lungs, in healthy lungs, you have resident alveolar macrophages. During inflammations, you have a recruitment of monocytes reaching the lungs, and they will become macrophages in the alveolar spaces, so they become monocyte-derived alveolar macrophages. So we question these two types of cells, moving back to a mice model when you induce a severe pneumonia. Mice usually are cured after 7 days, like in humans, and you can find here that we were able to find the resident alveolar macrophages and the recruited ones, the ones that are coming from the monocyte. Remember that the monocytes are the paralyzed one with low interferon gamma in the blood of ICU patients and low capacity of doing phagocytosis. What we observe is that when the monocytes reach the lungs, they acquire in the lungs a high capacity to do phagocytosis, while the resident one become paralyzed, and the monocytes are the one producing the more inflammatory cytokines. For instance, iNOS is highly produced by the monocytes. When we compare these two cells, the resident one and the monocytes, by transcriptomic analysis, so we are looking at all the genes, not only the one we thought about. What was striking was the differences between type 2 and type 1 interferon pathways. They were all upregulated in monocyte-derived macrophages and downregulated in the resident one, suggesting that this balance between residency and monocyte reaching the lungs is key in regulating interferon gamma response to patients. And we can explain that because the monocytes do express receptors for interferon gamma type 1 or type 2, while the resident ones do not express any receptor for these cytokines. So the concept that myeloid cell and the balance between these different subgroups is key factors in the regulations to immune therapies in severe infections such as sepsis was supported because we find this signature in different cohorts of published data, such as COVID-19 patients, but also patients with cystostic fibrosis. We always can find differences in the interferon response between these two kinds of cells. And when we move back to patients included in the PREDAP study, we observed that high recruitment of inflammatory monocytes in the respiratory fluid before the development of pneumonia. And when we looked at the monocyte from the same patients, we were able to observe that the interferon gamma treatment increased the ability of blood monocyte to reach the lung tissue by increasing expression of CCR7, for instance. And you can see that with interferon gamma, CCR7, which is this receptor making the homing of monocytes, is increased. And the total number of monocytes with interferon gamma doesn't change over time while it's increasing the placebo group. So what we propose is that during ICU, an interferon gamma completely change the host balance, the host microbiome balance by making more monocytes reaching the lungs, and these monocytes are pro-inflammatory. If it's the case for all patients, likely not. Some patients develop severe pneumonia, some others didn't during the treatment. So we try to understand if it was the case for all the patients. And we combine different omics, respiratory microbiomes, metabolomes, inflammatory panel, and cytometry. And we were able to define 3 clusters of patients. So one cluster of patients is very high risk of pneumonia, one has a lower risk of pneumonia. And you can see that it's also associated with survival, probability of mechanical ventilations. So these host microbiome interactions can already be associated and defined in different patterns. And for instance, I'm moving quickly on this one, but tyrosine metabolism is key in this mechanism because tyrosine is an amino acid regulating monocyte functions and microbiome functions. And very interestingly, when we applied these 3 patterns in the PREDAP dataset, we were able to identify that patients at low risk suffer from pneumonia, meaning that their monocytes remain susceptible to interferon gamma. So if you treat this patient with interferon gamma, they will suffer from that. They will stay a longer time in ICU. While if patients with very high risk, these patients have the immunoparalysis, so they don't respond to interferon gamma as well for the monocyte, you can restore partially this pathway with the treatment, and now these patients benefit from the treatment. So if we are able to identify this low risk, moderate risk, and high risk of patients, we can define responders and non-responders to ICU, to interferon gamma. Is it just science fiction? Not completely. You are perhaps already aware of this paper published last week by Evangelos Gemaros-Bourboulis. It's another Horizon Europe project. The Immunoceptual was trying to improve outcome of patients hospitalized in ICU for sepsis. Patients were characterized in 2 subgroups, one hyperinflammatory phenotype, which were defined by high ferritin level and high expression of DR expressions on monocytes, so no paralysis but very high ferritin level, and patients with immunoparalysis, which are defined by low expression of DR on monocyte. Patients received either interferon gamma or anakinra, and the primary outcome was a reduction of organ failure over the 2 weeks. And you can see here that the precision immune therapies for sepsis have an effect on this marker, which is not mortality, not, let's say, robust or strong outcomes, but precision immune therapies is effective. If I have, so it's a very important study showing that immune therapies personalized can work in septic ICU patients. So it's massive information and very useful for future to shape everything. One, if I want to really be in the futures, what is missing from these first studies is what we don't know exactly if both interventions work, or perhaps it's possible that only anakinra is efficient while interferon gamma has a limited effect in this study, because the 2 studies, the 2 arms are combined together. The comparison is precision immune therapies against placebo. So you are combining anakinra or interferon gamma in these groups. Again, what we all do, no immune therapy for sepsis. So what we propose for hospital-acquired pneumonia is to develop the same kind of thing that has been done in sepsis, but now to move back to hospital-acquired pneumonia. And so patients can be classified in different subgroups with hyperinflammatory who will not respond to interferon gamma, patients with hyperinflammatory response, hypoinflammatory response that can respond to interferon gamma. This patient can be classified by clinical score, microbiome signature, or resident or monocyte recruited macrophage signature. And now you can define completely different approach. In one patient, you can define that they will respond to interferon gamma, and perhaps you need to treat them with interferon gamma. In the others, it's the opposite way around. They will suffer because they have this imbalance. And so now the next trial for hospital-acquired pneumonia needs to be much more finely tuned, like it has been done for immunosub trial. So in conclusions, replacements of hypoinflammatory resident macrophages by reactive monocyte-derived macrophages in ICU during sepsis and severe pneumonia is a key factor to regulate immune therapies. Interferon gamma and JAK kinase inhibitor has been tested in COVID-19 patients with some effect, but we need to define which patients are responders and not responders. And the good thing with such immune therapies is that they are non-pathogen specific, so they can be very useful in case of highly resistant infections, but even in highly susceptible bacteria, we have treatment failure in 1 patient out of 3. So this immune therapy is likely will change the life in the next decades of patients suffering hospital-acquired pneumonia. I really want to thank the European Commission for these 2 Horizon Europe projects, which helped to develop all these tools and studies. And thanks my team in Nantes University with these 4 people mainly involved in all the results I showed today. And thank you for your time and your question and the kind invitations. Thank you.
Dear Antoine, thank you for your outstanding talk. And let's start with the questions. Just a minute, because I'm trying to see the question from here, and I have my own question as well. I would like to ask what do we expect now? What will be the following step to individualize immunomodulation? We have see the JAMA study of Professor Yamarellos of Immunosep, when to give interferon, when it was immunoparalysis, when to go with anakinra, when we have hyperinflammatory. What biomarkers we expect in the future to guide us? And is this time near?
I think the main thing for the biomarker is the difficulty to have access to a biomarker on real life 7 days a week, 24 hours a day. So we have different kind of things, and I will just chase what Jean-Francois Timsit has just said before. Clinical scores can be quite useful. So you can use clinical features to adapt the duration of antibiotics, but these hyperinflammatory or hypoinflammatory scores are not exactly clinically presented the same. So we defined the Phoenix score this year in the intensive care medicine paper, showing that with 13 clinical variables, you can identify immunological pathways in patients. So that's a way to do that. And like that, it's very feasible at the bedside for almost everyone. After that, we define we have several teams working on this phenotype. And I think it's very important to define and separate sepsis, which combine respiratory infections, peritonitis, cerebral infection, urinary tract infections, from very specific organ-specific features. So we are only working on pneumonia because we want to do precision medicines, and I think that the immune response to pneumonia is quite different to urine. So I think the next step would be to define organ-specific phenotype. That's what we are trying to do, and make that available at the bedside. And if we want to make that happen and daily applied, the kind of trial with the immunocept is what we need to do, because we will apply this biomarker only if we can show that it has an impact on the response of treatment. We need more treatment and more studies testing immune therapies, but also trying to understand what's going on the immune response and define a posteriori responder and non-responders. And these kind of things can be developed in platform trial. That's the one we are developing this year, which is a SHAPE trial where we will combine immune therapies together and try to identify responder from non-responder. So we are now at the very edge of these revolutions. So immunosep is the first step, and yeah, I'm sure that will come by showing effect on robust outcomes such as mortality, respiratory failure durations, and so on.
Thank you very much. Are there other questions or from Professor Makris, Professor Timsit, Professor Hakan? You're muted, all of you. Can I ask another question in the meantime? A tricky question, because now we are just having simple biomarkers, and let's say we have pneumonia. Want to decide if it is hyperinflammatory or not, to start steroids, severe pneumonia in the ICU. What would we use?
So it has been nicely shown by a meta-analysis published this year I think in Lancet Respiratory Medicine, showing that blood level of CRP can be used with a threshold of 15 milligrams per deciliters. That can help you to identify which patients for community-acquired pneumonia will be the most likely to respond to steroids. And so, as you know, at this point now, we are currently finalizing a randomized clinical trial for hospital-acquired pneumonia using dexamethasone. And we are using the same thresholds based on this literature on community-acquired pneumonia. So we are now at 50% of the patients recruitment. So likely in 1 year, we'll be able to hopefully confirm that this threshold is useful to identify responder to steroid for hospital-acquired pneumonia. So blood, I would say for steroid at this time, the easiest one and the most studied is blood level of CRP.
That's why I said a tricky question, because I wanted this to be out as well, that even now we have a marker that we can have an idea about the hyperinflammation. Professor Makris.
Yes, thank you, and congratulations for your presentation, Professor Roquilly. I would like just to point out two things. The first is that it is a major step if we can categorize our patients into patients who are let's say, in brackets, deficient or overreact after the exogenous stimuli. The second point, because we have seen this during the COVID period with the use of several different regimes, it has to be also interpreted on the context of the environment. For example, if we are just want to clarify that if we are in an environment here in Greece where we have PDR cases, it's difficult to know what will be exactly the implication in the whole population of our patients, because we may not control even the infection. And if you try to immunomodulate on this ground, you may not have the step forward you expect. In any case, congratulations. That's very, very nice and hopefully clinically important concept and step forward.
Thank you, Makris. I fully agree that the eradication and the control of the pathogen remain key, even if the immune therapies or host of microbiome-targeted treatments can also affect the virulence or the clearance of the pathogen. Yeah, we need to be sure that if we decrease inflammations, we will not increase the pathogen burden and making the virulent pathogen there. So yeah, we need to have these full integrations of pathogens, microbiome, and host to have a clear pictures. I agree with you.
Can I ask for a take-home message for all of us that we are not the experts in neuromodulation, intensivists or infectious disease specialists, or all those that are interested in infectious diseases?
Take a message if at this time for first episode of hospital-acquired pneumonia, it's probably too early except for clinical trials to start immune therapies. But when you are facing a patient with very difficult pneumonia to treat, so you are day 7, day 10, day 14, your patient still suffering from this kind of symptoms and inflammatory, I think there is room here for immune therapies, and the two most studies are interferon gamma to boost patients with a, let's say, hypoinflammatory phenotype, or baricitinib, a JAK kinase inhibitor for prolonged one that has been tested widely in COVID-19 patients. In this kind of patients, mortality is exceeding 50%, and there is probably rooms to to test and apply this treatment. But it's very extreme patients at this time, and immunotherapies remain for the early phase a clinical research part.
Thank you so much. It says if we have an intubated patient and from tracheal aspirate we have a result physiological microbe of upper respiratory tract, but it is a HAP deteriorated, intubated, and then you have a tracheal aspirate oral flora. What is your suggestion? And I think this question is for both Professor Timsit and Professor Roquilly.
Well, oral flora is really an issue. Probably there is a possibility for the community of bugs, let's say the respiratory microbiota, with some pathogens to induce early onset pneumonia. So in some cases, perhaps we need to cover this kind of things. If we look to the randomized control trial, there is no real, very clear-cut evidence of a benefit of the therapy of this kind of bacteria, let's say, oral flora. But in some cases, it induces somewhat early onset pneumonia. I don't know what Antoine is thinking about this point. Antoine?
Yeah, I think definitely when you have this kind of flora, I think it's all depend on the clinical presentations. If a patient's present with a clinical presentation of pneumonia, so he has fever, oxygen requirements, you will have to consider this as pathogen and treat them. We know that this respiratory microbiome has some good functions that you need to protect. So if you find this thing and patients with have a very non-severe pneumonia, as Jean-Francois nicely shown in his presentation, you can treat them, but very for a short period of time, I think. So this can be pathogenic. You should consider this, in my opinion, as non-antibiotic resistant bugs. And you have to reduce the durations, if possible, based on clinical presentation. Sorry,
we are not hearing you.
Okay, thank you very much, both of you. There is a question about blood cultures. And should we take blood cultures to everybody? I think this it is answered in the Survival Sepsis campaign as well. But it is a question in the chat. And then if we have a patient already antibiotics, if we should take blood cultures. This is two questions in the chat.
So probably to question the duration of antibiotic therapy, yes, it is clear that if you have some difficulty to be sure that the patient is clinically cured, it could be very interesting to repeat the blood culture, especially for Staph aureus infection and non-fermentative gram-negative infection, bloodstream infection, and candidal infections. If you have some positive culture, of course, a short therapy will be very difficult to use. And in my, let's say, watchful waiting strategy, probably it is important. If you decide to perform a very short therapy, and probably it is better to be sure that there is no relapse of the infection before stopping the antibiotic regimen.
Another question about duration. What recommended duration for NDM-CRE infection?
It is the same. I said before, probably if you look in deep to the literature, if the patient is controlled, even with colistin, probably there is no need to prolong the antibiotic therapy. If you look to all the data, in the specific subgroup with a very good clinical cure, there is no data that contradict the performance of a short therapy in this case. But of course, if you have not a real good control of the situation, there is a need to redo some bacteriological sample to look at some emergence of resistance, because usually the clinical relapse and recurrence is probably due to a non-optimized PK data and probably, let's say, MICs or resistant organisms. And you should probably decide, we go to escalate or discuss a combination therapy in this case. But definitely, there is no real reason to prolong the antibiotic therapy with the same molecule at the same dose if you have a clinical failure at day 7.
Thank you so much. And there is a question that combines the talk of Professor Makris and Professor Bassetti. They say, what do you think of combination therapy, ceftolozane tazobactam with colistin for NDM Pseudomonas? Professor Makris, are you there?
Yes, I do. For MBL, if
and NDM, yeah, New Delhi, yeah, for let's say MBL Pseudomonas. Ceftolozane tazobactam plus colistin.
But I don't have any data to suggest it formally. This is a combination that if we have some doubts about adding Astreonam, I don't know if it will produce something in terms of positive clinical outcome, since we know that colistin has several limitations in its as a molecule in terms of chemical characteristics. So I can't say if I recommend it or not. If colistin is one of the drugs which is there is susceptibility in vitro, yes, it could be used.
Yes, I agree. There are not data, a lot of data are out about the combination for the newer beta-lactamase agent. There are a lot of suggestions, small studies, but as far as I know, I agree that for MDM Pseudomonas, it can be considered, but there's no data. Hakan, do you have any input as microbiologist as well, infectious disease specialist? You're muted.
Thank you. Yeah, this is a very critical point. And, you know, all of us are facing this type of resistant problems in our ICUs. But the problem is, I think, in many parts of the world, is the development of colistin resistance at the same time. You know, what do you think, Doctor? I would like to ask to Dr. Makris. What do you think? What do you think that the added colistin resistance will cause problems in patients with beta-lactamase positive isolates?
Colistin resistance is a problem. We do have
combined with the beta-lactamase co-presence, you know, coexistence.
Even we have in vitro susceptibility to colistin, we know that this is already a problem because colistin is associated with some disadvantages. If you do not have susceptibility to colistin and you have resistance, you have a complete problem. And we do not have data that there is a synergistic action, positive, combining colistin with something else in a clinical scale that leave us to derive a firm conclusion. So I don't know. I know that it's a difficult question. I know that it's more difficult to give an answer. If you have a susceptibility to colistin, you will use it knowing all the disadvantages. And I'm not aware of data showing that if you use colistin in combination with whatever beta-lactam or beta-lactam inhibitor, you will have a superior, let's say, response compared to use Astreonam.
Yeah, we have, the problem is we face time to time, and I know some people face the same problem. We have patients infected with isolates that have that produce beta-lactamases on one side. On the other side, the infecting pathogen is also colistin resistant. So it imposes great challenges to us, I think. The developing world, starting from, Asian countries until Spain, I think there are such problems, and I don't know how to manage.
Because we are off the timing that it was supposed to be 1 hour and a half, it's just the last question in the chat that is for duration, and it's a duration about CNS infections. Unfortunately, we cannot do everything, cover everything, but let's, if you can, Jean-Francois, its duration again, it's about what is your suggested duration for CNS infection?
Well, it depends on the cause of the CNS infection. If you have an endocarditis, of course, it will be the duration of therapy for endocarditis. If it is a catheter-related infection, if you remove the catheter, probably 3 days is enough. There is no need for, and even 0 is perhaps enough. If you have no risk for no device, intravascular devices, and so on. So probably a short treatment will be enough. The very difficult problem is to differentiate contamination with real infection, and it is really a mess. It is very difficult. It is most of the time a combination of many CNS that are responsible for an infection. So looking at the same antibiotic susceptibility testing is not enough. You need to go to some molecular methods in order to be sure that it is the same organisms or not. So it is very, very difficult. So I would say a short therapy is enough most of the time. But of course, you should discard the possibility of intravascular infection and endocarditis.
Okay, so for coagulation negative, excluding endocarditis and excluding foreign bodies, shorter duration. And it's very important what you said about even if we see CNS, it may be other CNS from the skin flora and not be the same. Very, very good point. Many excellent presentation. Thank you for all of our presenters. I would like to thank you all that you bared with us, even with the initial technical problems. Thank you to FI for resolving. And many questions is about the certificate. If you have attended most of the webinar, I think it's like 80%, you're gonna receive in the following 10-15 days certificate. Second, in 10-15 days, a link for the recordings will be delivered. And also, after this period of time, 10-15 days, the recordings of the webinars are uploaded to the website of ISAC. As it was in the chat that the previous webinar on 24th is now reachable in the ISAC webinar. I would like to invite for the third part of the series that is co-organized by ISAC, ESGCIP, that means the ESCMID group of critical ill patients with infection and KINS critical care. It will be 20th of January, and it will be a change of time because we have some complaints. We need to accommodate also USA, Brazil, Northern and Latin American. So it will be in a way that we're going to accommodate early this continent, Europe, and at the same time, Australasia will be covered. You're going to receive from ISAC, from FI, when it will be exactly the third part of our series. Thank you again. It was a great participation both in the first and the second webinar with more than 1,300 registered today and more than 400 live with us. The rest will all receive the recording. Thank you again very much, all of you. Thank you, Hakan. Thank you, Fi, Antoine, Jean-Francois, and Demosthenes. And thank you to Matteo for sending his presentation. Have a nice day.
Thank you. Have a nice day. Bye-bye.